Hi, everybody. Thank you all for joining us for this webinar, which is part of our series of presentations funded by the Australian Government Department of Health, Disability and Ageing. And what these webinars and webinar series are all about is how to apply evidence into practice as part of our comorbidity project. My name is Christina Morell. I'm an Associate Professor, Deputy Director of Treatment and Translation Research and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney here, where I also lead the comorbidity project and work with a very good bunch of people, which is a great thing. And several of those people are joining me here today as we bring you the webinar today, which is being led by Associate Professor Julia Lappin. But before we get into that, I would like to acknowledge and pay respects to traditional owners of the country on which we're meeting and recognise that we are joining from many traditional lands across country. The traditional owners of the lands that I'm currently on are the Gadigal peoples of the Eora Nation, and I would also like to recognise their continuing connection to land, waters and skies, and acknowledge the same for the traditional owners of the lands that you're all joining from, and pay respects to elders, past, present and emerging, and any Aboriginal and Torres Strait Islander people who are joining us today. I'd also like to recognise and acknowledge the many people with lived and living experience in mental health conditions and substance use, as well as their families, carers and loved ones, many of whom have been involved in the comorbidity project and our development of our many resources. Whether you're joining us live or watching the recording, you're in listen-only mode, which means that we can't see or hear you. So I'd like to draw your attention to the Q&A and chat buttons on your screen. If you have any questions for Julia during the presentation today, please feel free to use the Q&A button. If you have any comments or anything other than questions for Julia, can you please use the chat button? And this just helps us keep track of what questions we pass on to Julia and whether there are any other requests for support or technical issues that we need to help with. The recording will be available for download for our website in the next few days. If you find the Zoom chat distracting, you can have a play around with the settings on your end to disable what messages you see. And to do this, you just need to go to the Zoom desktop app if you have it installed, click on the settings wheel in the top right-hand corner of the screen, select notifications and sounds on the navigation menu, and you can toggle off this option to preview messages or chats. And Madhu will post the link to do this in the chat if you want to have a play around with that later. Before I introduce Julia and hand over to her, I just want to mention you can access our webinar library at our website. The link to do that is also on screen, and we'll post that in the chat. And if you have a couple of minutes at the end of the webinar, please take a moment to let us know if you have any feedback or suggestion for future webinars that you'd like to see as part of this series. And thank you to those of you who have been doing that already. And we are going through all of that feedback, and we will be seeing what we can do. And now it's my very great pleasure to introduce our presenter for today, Associate Professor Julia Lappin. Julia is a consultant psychiatrist at the Prince of Wales Hospital in Sydney and led the development for the New South Wales Tertiary Referral Service for Psychosis, a statewide service for New South Wales, and served as its inaugural clinical director for 5 years. She currently runs implementation projects for interventions which improve the quality of life in people with mental health disorders. Julia has a broad range of interests across research and clinical practice with a focus on improving outcomes in mental health disorders, particularly mental health harms related to substance misuse. Some of you may know that Julia presented a webinar with us several years ago, and even though that webinar is still part of our library, we asked Julia to come back, and I'm so very pleased that she agreed because our webinars are always incredibly topical. So thank you again, Julia, and I'll hand over to you to get started when you're ready.
Thanks, Chris, for a lovely welcome. I'm delighted to be back presenting with everyone, and I'm just loving the chat, everybody joining from states all over Australia and New Zealand, which is just fantastic to see. I'm just going to check, can I get a thumbs up that my slides are sharing?
Perfect.
Great, thanks. So everyone, as Chris said, I'm a psychiatrist and I've had for many years a strong interest both clinically and in research in psychosis and in drug-related psychosis, and that's what I'll be talking about today. If I can just move through the slides. There we go. This is an outline of today's talk. These are the main topics that I will move through during the course of the talk. So we'll start with background. What are the most commonly used illicit drugs? This will be known by many of you, so I'm just going to touch on it, but it is relevant because these are the drugs that we see people using, and there is background of people using these drugs who present to emergency departments with psychotic symptoms. So importantly, first is cannabis. Many of you will know about cannabis derived from the cannabis sativa plant. Includes marijuana, cannabis resin, hashish oil. Really, cannabinoids refer to any chemical which act on the cannabinoid receptors in the brain. And this includes prescribed cannabis. And it's really important to be clear about this. This is true of all drugs. A prescribed stimulant acts on the same neuroreceptors as an illicit stimulant. The same is true for cannabinoids. And that's important because some people think that because they're prescribed a tablet that it's safe, but it still has potential for harm. THC is the cannabinoid in cannabis that's responsible for most of the psychoactive effects. And so importantly, depending on what form or dose of drug people are taking, it's the THC component, which is the one that can convey psychotogenic effects like hallucinations and delusions, and we'll get to that. So cannabis can be smoked or ingested or now taken as a tablet if it's medically prescribed. And the effects can hit within seconds of smoking and last for several hours. And the main effects, the main reasons why people take cannabis are for a sense of relaxation, a sense of feeling good, euphoria, and whether good or bad, a side effect maybe is that it stimulates the appetite. Moving on from cannabis, we have another class of drugs, the psychostimulants, and these are really amphetamine and methamphetamine. The main psychostimulant taken in Australia is methamphetamine. Importantly, when it gets into the body, it's quickly broken down into amphetamine. So really you can talk about methamphetamine and amphetamine as being much the same drug once they're in the body. It's been produced in various forms, both legally and illicitly, since the 1950s. So it was prescribed for many years to help lose weight. It can be prescribed in conditions like ADHD and sleep disorders like narcolepsy. In Australia, as I say, most of illicit psychostimulant use is methamphetamine. 2/3 of users are male, and the majority of users are in their 20s and 30s. And that's true also for cannabis and really all illicit drugs. Crystal meth is a special form of meth which is high potency. It comes in a crystalline form, that's how it gets its name. It can also be referred to as speed or ice by users. And it's particularly harmful because of its high purity and its high potency. That means it gets into the bloodstream and into the brain very quickly, and it acts almost instantly and with large effect. And these rapid effects are euphoria, activation, anxiety, delirium, but also sometimes a real agitation if the activation goes too far, and there can be psychotic symptoms. The final drug class I'm going to touch on is the psychedelics, also known as hallucinogens. These include LSD, PCP, ketamine. Again, ketamine now prescribed, and other psychedelics coming into use more commonly in medical practice. The effects of these drugs, again, onset within an hour. Again, people are getting the euphoria, a dissociative effect, a sort of feeling of being slightly detached and separate from your body and from the world around. Some people find that pleasant, some don't. And you can, again, get hallucinations, hence the name hallucinogens. All right, I'll move on now and talk a little bit about the main topic of the talk, which is drug-related psychosis. So what do we mean when we talk about drug-related psychosis? This specifically means that we're getting signs or symptoms of psychosis in the context of drug or substance use. And for the actual formal definition in diagnostic schedules like the DSM or the ICD, it states that symptoms should develop during or within a month of substance intoxication or withdrawal. And importantly, substance use should be etiologically related to the disturbance, and that means it should be part of how the disturbance comes into being, should be part of the cause of it. And this is the thing that troubles, I think, in real life practice. This last point is the thing that confuses most people. Symptoms are not better accounted for by a psychotic disorder that the person might already have. So I want us to think a little bit about what is the value of the term drug-related psychosis. So this is basically, when we're talking about psychosis, we're talking mainly about the experiences of a distortion in reality, which is unpleasant and distressing and causes difficulty for the person. They can be hallucinations, so seeing, smelling, or hearing things that other people don't, and delusions, which are fixed false beliefs that might cause someone to change their behavior because they become paranoid, frightened, suspicious, or grandiose belief that they have powers, abilities that they don't have, for example, to be able to fly. What happens specifically when people use a substance is that we get psychotic symptoms. But what clinicians often struggle with is whether the psychotic symptoms are occurring as a direct effect of the substance or whether the substance is unmasking a vulnerability that the person already has for psychosis. Increasingly, we have been able to conduct studies over many years to look at people who have a first episode psychosis in the context of substance use and look at what happens to them over many years. This is important because people think, oh, you get a few hallucinations when you take a drug. That's pretty normal. That doesn't mean you've got a psychotic episode. But for some people, actually, it does, because different people have different vulnerabilities to the later development of a psychotic illness. So what we need to do is follow up people over time to see what happens to them. And this is what we tried to do. The other very important issue, and this is part of why the Matilda Centre does all the work on comorbidity, is that it's extremely common that people with mental health issues also use substances. And just because two things are happening at the same time in one person doesn't mean that one causes the other. Of course, it might, but there are also other explanations, and we'll look at those throughout the course of the talk. I want to touch first on this point and talk about a study that I was involved in, which looked at these long-term outcomes, following people up over many years to see what happens to them after they present with a drug-induced psychosis. And really the question we're asking is, does someone who presents with psychosis in the context of substance use end up having a chronic psychotic condition like schizophrenia? So schizophrenia is a severe form of psychotic illness where people have either continuing symptoms over many years or a relapsing remitting course where they have periods of at least 6 months at a time where they have psychotic symptoms, and they have typically, really quite impaired function. Many will not be able to work. Many won't be able to sustain relationships or be part of the community for years afterwards. So clearly that's a bad outcome. And it's important for us to know how many people who have a drug-related psychosis go on to develop this severe form of chronic illness. So in the background, we know that brief periods of psychotic symptoms in the context of substance use do happen for many people. In fact, in Australia, it's estimated that between 1.5 and 6.5 of 100,000 person years, this will occur. And up to 25% of first hospital admissions for psychosis may include this diagnosis. But people who present with drug-related psychosis are sadly often excluded from mental health service follow-up, at least for the first few years of presenting, because people think, oh, it's just psychotic symptoms in the context of substance use. However, we do know that a significant proportion of these people do later transition, develop a chronic psychotic illness or schizophrenia. And we wanted to look at this in all the studies that have been conducted over years, bringing them all together in a systematic review and meta-analysis. So what we did was we compared different forms of first episode psychosis presentations. I'll just talk you through these so that you understand what the columns refer to. Yes, we were interested in how many people with substance-induced schizophrenia later developed substance-induced psychosis, later developed schizophrenia, but we also wanted to look at other groups, including psychotic episodes, which are defined as brief and atypical, so they last less than a month, not otherwise specified, which is just, they weren't clearly defined, or schizophreniform, which is where people present with lots of the symptoms of schizophrenia, including paranoia, hallucinations, delusions, formal thought disorder, which is a distortion of speech and thinking. And then we looked overall. So first episode psychosis will overall transition to this very severe chronic form of psychosis in 44%. That's your overall on the far right-hand side. And substance-induced psychosis, 25% of those people will develop a schizophrenia. And that's why it's very important to look after these people in ED when they present for the first time and follow them up, because a quarter of them are going to have a very chronic disabling illness. What we found in our meta-analysis was it's very important which substance is involved. And this is really important to know because we must ask about this. Yes, there can be polysubstance use in many people, but cannabis is the outright winner. If cannabis is involved, it holds a greater likelihood that that person will go on to develop schizophrenia in later life. So 1 in 3 people who present for the first time with a cannabis-related psychosis will develop schizophrenia. The hallucinogens, so these are the group that I talked about earlier, LSD, ketamine, etc. About 1 in 4 of those, about a quarter of those people who present with a hallucinogen-related psychosis will develop chronic schizophrenia. And the amphetamines really come in next, about 22%. So this is a serious issue, particularly for cannabis, hallucinogens, and psychostimulants. So our findings show that more than 1/3 of people with cannabis-induced psychosis develop schizophrenia, and that the rates of transition are higher among younger people. That's important because psychosis tends to onset, certainly has a blip, particularly in men before age 25. There's also something about this exposure. Many, many more people use drugs in their late teens, their 20s and their 30s, and that's probably why we're seeing this combination of drug use leading into psychosis, or the two being present together at the same time. Importantly, though, what we looked at in all these people was what are their other risk factors for schizophrenia? Does the psychosis just come on in and of itself just because of the drugs? It's very, very difficult to know the answer to that question, but we can interrogate it by saying, well, what other risk factors did these people hold for developing a psychosis anyway? Might they have got the schizophrenia anyway, even if they hadn't used substances? And the type of risk factors that increase your risk for psychosis are family history, so a first degree or second degree relative with schizophrenia or indeed any psychotic illness, genetic predisposition, which is linked to family history also minority status, be that sexuality, ethnicity, your language. These all herald a greater risk for the later development of psychosis. So it's important to look for these risk factors in anyone who's presenting. And I'll just finish talking about this study with a schematic from a related study. This was a huge study from Finland. They've got big case databases in the Scandinavian countries, which allow us to track people over many years. And what this study shows really very much aligns with what our meta-analysis found. I'll just talk you through this graph in case it's confusing. We've got time along the bottom. This is how many years after their first episode at time 0 it took these people to convert to schizophrenia. And you can see that the probability up the y-axis is greatest for cannabis. Here they found that about over 40% of people with cannabis-related psychosis would develop schizophrenia within 6 years. Next came amphetamines, next came hallucinogens. Just going to draw your attention to alcohol at the bottom. You might say, oh, that's not too bad because look, only like 8% of people develop alcohol-related schizophrenia. But let's not forget that alcohol is much, much, much more commonly used, very commonly used substance. And actually, the number of schizophrenia cases related to drugs is actually greatest for alcohol because so many more people use alcohol. Proportionally smaller as a percentage, but in the real world, many more people using, and therefore prevalence is high for alcohol. So don't forget to ask about alcohol. Okay. So what I hope I've demonstrated there is that there is a high proportion of people who present with drug-related psychosis who go on to develop a chronic, enduring psychotic illness. I'm now going to have a look at why is it the case that so many people have comorbid psychosis and substance use. And these are the possible explanations, really, that we've thought about. Don't just mean me, but experts in the literature and clinicians over many years have tried to think about, why do we see so much comorbidity? And largely 4 possible explanations, all of which can be true, it's not one or the other, include that there are shared risk factors which predispose people to both psychosis and substance use. So, for example, childhood trauma, adverse life events, or genetic or environmental factors increase someone's risk of having mental illness, also increase someone's risk for developing drug use or misuse. I'll not talk any more about that one, but I'm going to talk about the next 2 points in a bit more depth. The other is that there's a causal link between substance use and the development of psychotic disorders. And there's a fair amount of biological support for the idea that substances like cannabis and psychostimulants and hallucinogens release neuroreceptors in the brain that are implicated in psychotic illness. And really, we're talking about dopamine here. So psychosis is an illness where we see way too much dopamine in the brain. Dopamine's your sort of your vigilance neuroreceptor. So people are alert, they're seeing connections where there aren't connections, they're experiencing perceptions, hallucinations where there isn't a stimulus. That's too much dopamine. And all these drugs, hallucinogens, psychostimulants, and cannabinoids, increase dopamine in the brain. So that's your sort of biological model of why you could get psychotic symptoms following using these substances. The next important point is that people who develop a mental illness, and here we're talking about psychosis, but it's true really for any mental illness, use substances to take the edge off, to quieten down the hallucinations, to get some sleep, to get out of their head. They self-medicate, and that might increase therefore use of substances among the mental health population. And finally, high rates of comorbidity can be due to the fact that it's very, very difficult to stop using substances. And it's particularly difficult for people with mental health issues and psychosis in particular. People can be very isolated. They don't have great coping strategies, and they can't perhaps articulate their needs or access the supports that they need to try and quit. So let's just look at these biological models of psychosis. I've talked to this really, so I'm not going to speak on it again. But all these substances can precipitate and maintain psychotic symptoms through a variety of your brain neurotransmitters and mainly dopamine. Let's look at the evidence for cannabis-related psychosis. For cannabis having a causal influence in the development of psychosis. We know from studies that have been conducted internationally that heavy use of cannabis increases the risk of later psychosis. If you administer THC to volunteers, you can get transient psychotic symptoms with dopamine release in the striatum, that's part of the brain. There are plausible biological explanations for the psychogenic effects of cannabis. And importantly, we know that THC in cannabis that's available is increasing and has done so over the past couple of decades. And with this high potency cannabis, we see a greater increase for psychosis risk. Again, particularly in those who hold other risk factors for psychosis. And this is something that we're going to talk about next week as well in the case discussion, how we've got to look for these other risk factors in an individual. Methamphetamine-related psychosis, again, we know that there's a link here among methamphetamine users. There's a much higher than usual prevalence of psychosis. We know that when people take meth, chronic users, the more they use, the higher their dose and the higher the frequency of their use, the greater is their likelihood of psychotic symptoms. So that's like a dose effect relationship. And there's significantly increased risk of schizophrenia in methamphetamine users. So this all supports the idea that there's a causal link between the use of the drug and the development of psychosis. But what about if we think about it the other way? Can psychosis lead to substance use? What do you think? You might want to put that in the chat. Can psychosis lead to substance use? Just say yes or no. I'm not going to say it, but Chris will be able to say it and can maybe bring that up in the Q&A. Can psychosis lead to substance use? All right. Well, they looked at this in another great Scandinavian database study. They had thousands and thousands of people to look at, and they looked to see among people with schizophrenia in the 10 or 20 years following that diagnosis, how many people had new onset of a substance use disorder that they didn't have before. And here's the findings. I'm just going to talk through the highlighted sections. So it was a huge cohort. We had 3 million individuals, 100 million person years were looked at. And of those, 14,000 individuals developed schizophrenia. And of those, almost 3,000 subsequently were diagnosed with this substance misuse disorder. That means that a diagnosis of schizophrenia was 3.69 times more likely to result in the development of substance use among people with schizophrenia compared to the general population. And so what they conclude is that a diagnosis of schizophrenia is significantly associated with increased risk of subsequent diagnosis of substance misuse. So the answer to the question is yes, it does go both ways. mental health, particularly psychosis, can also lead to the development of a substance misuse difficulty. And why would that be? So this is actually an editorial that I wrote for Addiction based on this great paper by Peterson, looking at what are the reasons why people with a severe mental illness like psychosis might go on to develop schizophrenia. And look, there are many reasons. Why does anybody develop a substance misuse habit? They're dealing with difficult symptoms. They're dealing with a fallout in their relationships, in their life, in their work. Nothing makes sense anymore, and perhaps substances provide some relief. I've already talked to that. I'm just going back to this, just framing where we are in the talk. Again, at the moment, we're just thinking about why are there such high rates of comorbidity? And the final explanation is this idea of the high rates due to inadequate supports to help cessation. And quitting is really difficult. People with severe mental illness or psychosis in particular, we know are very socially isolated. They have poor social supports. They're very paranoid and suspicious in general. They don't trust people. They withdraw from relationships, spend lots of time on their own, might not speak to anybody for weeks or months. They have, therefore, additionally inadequate support to cessation services. They don't have family. Maybe, of course, some of them do have family members who do a wonderful job, but many people who don't have family members, therefore, don't have the support they need to get them to cessation services. And they don't have things to do during the day. They're not employed. They don't go along to clubs and things. And so once you start using substances, it's perhaps difficult to find things to distract you from that. There are also sort of illness-related difficulties, like difficulties with cognition, high levels of impulsivity, poor coping skills, which might contribute. Okay, just keeping an eye on time. We'll have to move quite quickly now. I've been talking too much. So that concludes the section about why we get these really high rates of comorbidities. And now I just want to touch on what are outcomes like for individuals with comorbid substance misuse psychosis. This is a really wonderful paper by Grant Sarr and his team, conducted in New South Wales, looking at substance use diagnoses at first admission for psychoses. About 1,000 New South Wales patients who presented between the ages of 15 and 29. And you can see in the top maroon bar that of all those first episode psychosis presentations, substance use was identified in half, 50%. So we must always ask about it. It's so common. Alcohol was 14% of that, and illicit drugs were 46%. Numbers don't add up because you can have more than one. So that's sort of what's going on. That's the use pattern among people presenting to emergency department with substance-related psychosis that leads to an admission. So quite serious. Now, this graph shows us what happens to those people over the subsequent 2 years. So along the x-axis, we've got time, days to second admission. So we're looking at a period roughly 2 years. Days to second admission we're using as a proxy for relapse, because if someone has a severe relapse, they'd need to be readmitted. The bottom red block, red line, shows among people who were using drugs when they presented with their first episode and then said, right, that's it, no more, I'm not using drugs anymore. It was the drugs that caused my psychosis, might be their rationale, whether that's true or not, we can explore. But they say, okay, I'm not using drugs again, don't want to go through that again. 40% of those people are readmitted. That means about 40% of them will have a relapse, even though they stop the drugs. But they are actually the group who do best. If you presented the blue line now, if you present it without any substance use, you're actually more likely to be readmitted than those people I've just mentioned. About 50-50 that you'll have a relapse within 2 years. So about half of people have a relapse within 2 years, even though no drugs are involved. And that's because psychosis is a relapsing and remitting illness. Some people only have one episode, but they're actually very rare. Most people have psychotic episodes or continuous illness for the rest of, it's possible for the rest of their life. That's about 2/3 of people. So these people in blue, why are they at greater risk of relapsing? And this is where we talk about the vulnerability to psychosis. So let's say, thinking about these people developed psychosis even though they didn't use drugs. So they already had a vulnerability to developing psychosis, perhaps because of family history, perhaps because of minority status, perhaps because of adverse childhood events that meant they got psychosis. They didn't need a substance to sort of trigger them to a threshold. So they still have those risk factors 1 year later, 2 years later. But the people who use drugs to get to that first episode psychosis, if they stop the drugs, their vulnerability is a bit less. They needed drugs to tip them over into psychosis. And so some of the lucky ones whose vulnerability is lower don't relapse. The final group who do worse are the ones who keep using drugs. They were using drugs in the context of their first episode psychosis. This is the top dotted line. They kept using drugs. And 2 out of 3 of those are going to come back in. So in summary, we can say to people who present with psychosis in the context of substance use, we can say to them, we know that people who stop using drugs tend to do better. We can't say if you stop drugs, you won't have another episode. We can't know that, and it's clearly not true from this graph. But we know that people who stop using drugs do better than people who continue to use. Why is this important? It's important because comorbid substance use is really associated with greater harms, greater rates of relapse, rehospitalization, higher rates of violence, higher rates of suicide, higher rates of all-cause mortality, and additional comorbid mental health and physical health issues, cardiovascular difficulties with psychostimulants, anxiety, depression, PTSD, really almost any illness you can think of, increased risk among people with comorbid substance and mental health difficulties. And outcomes are also poorer among this group because they use services differently. Now, we know this about people with substance use difficulties anyway. They're a difficult to reach group. They're less likely to seek help. They're less likely to take treatment. They're less likely to come to appointments or engage in care. In fact, they often present in crisis to ED, and that's why ED is such a great opportunity because they're there in front of you. I've talked to GPs who say whenever someone with substance use comes in, they do a whole raft of tests and give them loads of support while they're there, trying to sort out as much as they can, because this is their opportunity. The person might not come back again if you give them an appointment in 2 weeks. It's the same at ED. Try and do as much as you can to help when you've got them there in front of you. But sadly, at the moment, what happens is it's all a bit fractured, the care that the people receive. They come to ED, they get a quick fix up, they get the way and in ED until their acute behavioural agitation settles, and then they're led away home because there's someone who maybe causes a bit of a disturbance and nobody really wants to invest too much time. They're not willing to share their family or contact details with you, and clinicians just sort of think, okay, well, we'll let them go on their way. It's probably not serving them best, but it's not a judgment because it's often difficult to help. But if people are willing to receive help, take the opportunity. There's also a bit of a silo. This is a really well-known phenomenon, and it's particularly true for psychosis and comorbid substance use, that Drug and alcohol, people think, well, it's psychosis, that's the mental health services who should be looking after that. Mental health services say, oh, well, he's injecting meth, he needs drug and alcohol. We can't deal with that. They will receive care for their psychosis in mental health services and receive care for their substance use in drug and alcohol services. But we don't have much co-working. There's been a lot of work tried to be done in Southeast Sydney and other areas trying to get comorbidity happening, but it's difficult, and it comes down to sort of where money flows in health departments and so on. Now, listen, I'm just keeping an eye on time. I'm going to move on to talk about managing comorbid substance use and psychosis. I do touch on this in next week's talk as well, though I understand that not everyone can come to that. And so I'm going to go through the basics of how we approach management. But next week, if you come back, we're going to frame the discussion around a couple of case studies. The first is Jaden. What would you do for Jaden? That's what we'll look at next week. And also Kyla. So both presenting with psychotic symptoms in the context of substance use, but at different stages. And we just want to explore how we would approach care for both of those individuals. We're not going to do that today. We're just going to go with the principles of what is a good approach to management in someone with drug-related psychosis. These are just basic, good practice pointers. Think about the individual. Think about what their needs are. Don't see a diagnosis, see a person. Be holistic in your approach. Try and understand if the person is open to engaging in ongoing mental health care. Try and get families and carers involved, because they really can facilitate getting people to appointments, addressing the problem. You really can get great gains if you have a champion. It doesn't have to be a family member, but someone who really wants to engage the person in care and get them along to appointments and open the door when services come to visit. Similarly, they should be cared for in drug and alcohol services. Let's see if there are integrated or coordinated care options. That's where both mental health and drug and alcohol services work together to deliver a care package. It's rare, but even if you can just be on the phone to your colleague in the other service saying, we're both looking after this person, and try and approach it in a joined up way, that is tremendously helpful for the individual and for the family. And look at where local NGOs can help with support. What are the absolute basic tenets of how we approach treatment for a psychotic episode? Well, we would offer antipsychotic medication. That's first line. You'd take it for a minimum of 4 weeks. Ideally, you would be maintained on it for at least a year. Ideally, you'd be followed up by a psychiatrist. You'd be case managed in a mental health service. And you'd be seen by that psychiatrist or GP at least 4 times in the first year. There would be psychoeducation for the individual and for their support network, and there'd be family work or interventions as relevant. And then CBT, cognitive behavioural therapy, for those with persistent symptoms. These are all in international guidelines. This is the approach that's recommended in the States, in Australia, in UK, across Europe. These are well recognised approaches. And for substance use, depends on the substance. Sometimes you can have a substitution drug that's really, we know it works for opioids. For the other drugs, much less clear. So the things that are really evidence-based are group counselling, contingency management, which is where, you say to someone, okay, well, I'll give you a reward or a coupon or money if you stay off drugs, and you can give me a negative urine test each month, for example. That's an example of contingency management. Residential rehab treatment is really the gold standard. It's very hard to get people in. It's hard for people to agree to go. And your approach should be non-judgmental. You should be assessing risks to self, STDs, self-harm, vulnerability. Often people, particularly young women, find that they must fund their drug habit through sex work. This is all, again, this idea about being holistic, taking the opportunity, do a full screen, give them help where they need it for their whole body, not just for their drug use. But also assess risks to others. Are there minors in the home? Are there babies in their care? Are they driving? Are they operating machinery? Check supports. This is, again, I've said this, families can really make a difference, though it can be very, very stressful to support someone with these difficulties, particularly if they're not open to engaging in help. And assess the individual's readiness for change. People who work in drug and alcohol know about this. You're really hammering on a closed door if the individual isn't ready to come to the table and say, yeah, I've got a problem, I want to stop, can you help me? But even as a basic, even people working in mental health services, you can make substance use monitoring part of the care plan. Ask about their substance use, be non-judgmental. Don't be shocked if you find they're still using, they may be using multiple drugs. Don't forget to include alcohol in your list of questions. And what we do in the short term, again, this idea of treating both conditions concurrently, referred both drug and alcohol and mental health, or liaise with the other one, refer to psychologists if they're motivated, and if there is a psychologist available. Psychologists just tremendously helpful, CBT, evidence-based, for management of both conditions, NGOs, family support. And longer term, expect relapse. Both conditions will be prone to relapse. Contain anxiety, be there through the successes and failures, deal with physical and mental health issues opportunistically. And again, I've talked about CBT and residential rehab. And just one or two more slides. Again, this idea just to explain the integrated approach to care. We know that in comparison to separately provided care, one in drug and alcohol, one in mental health, if the two come together, we know from studies that it results in better outcome. People less likely to present to ED, get better faster, less likely to go to hospital, less relapses of both conditions. But it's rare that services are organised in a way that allows the delivery of a coordinated approach. So that's maybe, a sort of a bit of a lofty goal at the moment. So, final slide, just to conclude the main points from today's talk. Substance-related psychosis is really important, and it's a common reason for people seeking mental health support. More than 1 in 5 first hospital admissions for psychosis in young Australians are drug-related. People with drug-related psychosis are often excluded from mental health services because people think, oh, it's just drug-related, it'll go. But we know that that's not the case. It's not benign or self-limiting. And in fact, the transition rate to schizophrenia is about a quarter of people, about a third in cannabis. Outcomes are better if you abstain, but remember that abstinence does not mean that you definitely won't get another psychotic episode. Remember, about 40% of those people did from that graph before. So people are starting on a trajectory. We don't know what their trajectory looks like when they're in ED with us at that first episode, but we do know that chances are many people will relapse. Many people with chronic psychosis will develop substance misuse in the years following their psychotic illness. And finally, treat psychosis and substance use concurrently and ideally offer integrated support across drug and alcohol and mental health services. And with that, everyone, I'm going to stop sharing and hand back to Chris, and we'll have the Q&A. Thanks very much.
Thank you so much, Julia. What a brilliant presentation. So much information and so much clear takeaways for us in the community. We have lots of questions. So thank you, everybody, for posting in the chat. We do read all of your chats. If we don't get to it now, we do after. And I wonder if I could start with possibly, and I have my eye on the clock, but we'll absolutely get as many questions to Julia as we possibly can. I might start off with possibly the simplest question, Julia, which was about one of the papers that you mentioned earlier on. It was the study, does substance-related psychosis progress to schizophrenia? Someone's just asked if we could just grab the title of that paper. Do you mind just letting us know what that paper is again?
Sally, can I suggest that I will send that to you?
Brilliant.
And then you can distribute it. I do have it. It was actually, the lead author was Ben Murray.
I've posted it in the chat.
Brilliant.
Oh, you did. You're a star. Thanks, Chris.
Excellent. Thank you so much. So let's move to some of the other questions. I'll start at the top. We've got one about THC here. So does THC work on the same or similar serotogenic system receptors as psychedelics? I am seeing some people with psychosis experiencing serotonin sensitivity.
Yes.
Chris?
Yeah, that's a great question. And look, I think we're still finding out the details of all the receptors that cannabinoids work on in the brain. We know that there are cannabinoid receptors in the brain, and they can cause all sorts of feed forward and feedback cascades that affect a number of neurotransmitters. So while I talked about dopamine, it's not only about dopamine. We also see dysregulation of serotonin and other neurotransmitters, and that's still very much in basic science, something that's still being explored. What do all these receptors act on? What do all these drugs act on? And it's also really important because there's so many different components of cannabis, and all these drugs work in slightly different ways. So it's a huge area of research.
Thanks, Julia. Stick with young people here. It's a very specific question. Is it recommendable the use of THC oil for treating autism spectrum disorder for a child of 15?
So do we have scientific evidence that medicinal cannabis is useful in the management of autism? To my knowledge, we do not yet. I know that there's lots of people are hopeful that medicinal cannabis will help with many conditions. To my knowledge, there's been a large systematic review that's shown that it is helpful for a small number of conditions so far. That's all we have evidence for. So.
Thank you. And then the last one we're going to get time for today, in terms of transition rate to schizophrenia based on substance use, you mentioned this applies more to people under 25. Is there any evidence that as you age into 40 to 50 plus, the transition rate decreases?
So I just want to clarify that a lot of the evidence has looked in younger populations because there's higher rates of substance use in those populations. It's absolutely possible to develop psychosis at any age, and it's yes, still possible to have a drug-related psychosis in your 40s, absolutely. The rates are higher among younger people, but there's still very much there in the 40s, 50s, even in the 60s and 70s, you can develop a first episode psychosis.
Thank you, Julia. Chris, thank you so much again, Julia. I'm really looking forward to the next presentation, as I'm sure we all are here. And Chris is just going to close us out. Thank you, Chris.
Sorry, trying to share my screen very quickly again. And of course, thank you so much, everybody, for all your engagement. And I know there's a bunch of questions that we didn't get to. And thank you so much, Julia. And everybody, just wanted to quickly let you know that you can find out more information about our guidelines, which this webinar series is linked to, and our other resources at our website there on screen. And for all you practitioners out there, what was mentioned a few times that we alluded to, we want to let you know that we are excited to tell you about our online community of practice, which is also funded by the Australian Government Department of Health, Disability and Ageing. That's available, and it's for professionals in Australia who work with people experiencing co-occurring AOD use and mental health conditions. And that is what Julia will be speaking as part of next week. That's free. You can find out more about it and register by clicking on the link on screen there. Actually, I don't think you can click on it, but Madhu will put that in the chat, or you can navigate through our homepage, just Community of Practice Comorbidity Guidelines. You can probably Google that too. Thank you again for having joined us for this webinar. If you're interested in having a look at our library of past webinars or watching this one again, catching up on anything that you might have missed, I know there's a lot of information in there and lots of questions. You can share it with your colleagues, and you can do that via our website. And we are in the process of lining up our next speaker and topic, which we hope will be before the end of this year. So stay tuned for that. But until then, thank you again for joining us. Thank you again so much, Julia. See you next week, and please enjoy the rest of your day.